start again. All right. I skipped over this slide the last time, and I regretted doing that.
Yes.
Because I really think I want you to know exactly where things are, or where to hear things. So I copied and pasted a little further down, so we can actually go through it this time, okay? So murmurs, where are they heard the loudest, okay?
What slide is that here?
58.
It's 58 and then it's 60 something again. It's a little further down. There we go. All right. Yeah, I copied and pasted it a little further down just because I wanted you guys to look at it. So we know where the spots are that we want to look at, where we're going to listen. So we know where the aortic valve is, and if I ask Octavia really quick, she'll tell me that is right sternal border. Beautiful. You know? And we know what the mitral valve is because you're going to tell me exactly where it is right now. Quick.
It's
See my face right now? You see my face? It's the mitral valve. That's right. Fifth intercostal space, mid-clavicular line. Okay. Where did we say we're going to listen for the point of, we're going to feel for the point of maximum impulse?
7 to 9 centimeters left sternal border.
And we said that what sits there? The apex. Okay. If we want to hear something from the mitral valve, where would we listen?
Left sternal border, second intercostal space.
mitral.
Mitral? Oh, just kidding. Just kidding. Sorry.
I can't believe you just said that. Really? You just said that to me.
Okay.
Okay.
That was a mistake.
So those in red are the systolic murmurs. Okay? Those in blue are the diastolic murmurs, and then the septal defects are in green. Right? So second right intercostal space we know is the aortic. And we said aortic stenosis radiates where?
So left carotid.
Left carotid. Okay? Now, that's a systolic murmur. What's the next systolic murmur from the valves? Quick. Tricuspid regurg and mitral regurg. Okay? Those are the next two systolic murmurs. Where are we going to listen for this other systolic murmur? Well, pulmonary stenosis is also a systolic murmur, but you hardly ever hear that. Where do we listen for mitral regurg? Left sternal border, mid-clavicular line. Where does it radiate to?
Axillary.
Axilla. Okay? Now, if you look, where is the pulmonic valve? When we listen for pulmonic issues, where do we listen?
Second intercostal space.
Okay? And if you look for where the pulmonic valve, pulmonic regurgitation is, we're going to listen right there. But look at aortic regurg. Look at where you hear aortic regurg best. Where is the light?
What is that?
Oh, it's on.
At this.
There we go. Look at where you hear aortic regurg best. Where is this area right here where I'm pointing at? Erb's point. Okay? So if we want to hear aortic regurg, the best place to hear aortic regurg is not right second intercostal space. It is actually left of the sternal border at the third intercostal space where Erb's point is. And this is one reason I really wanted to go back to this slide, because aortic regurg, when you listen to it, it's not exactly where the aortic valve is. Okay? So you want to pay attention to that. Okay? When you're listening for mitral stenosis, you're going to listen in the lateral decubitus position or lateral recumbent position. Okay? So if someone has a murmur of aortic stenosis, you're going to put them to lay on their left side, put their hand behind their head, and have them lean a little bit forward. That's left lateral decubitus position that they're going to lay in. Okay? For tricuspid stenosis, say that again.
No, but that's what you said for the mitral stenosis, right?
Yes, mitral stenosis. Mitral regurg is at the apex. All of them are basically almost at the apex. Everything for the mitral is right in that mitral area. Okay? Now, patent ductus arteriosus, you hear this mostly in babies or younger kids, because usually if the patent ductus does not close fully, if it's a small opening, you'll hear a small murmur. Okay, and the small murmur you will hear it right at the inferior left clavicle. Okay, it's a holosystolic murmur that you'll hear. Usually in babies, maybe the second, third day of life, that closes. Now if it stays open, it does not always need surgery if it stays open. Patients are asymptomatic and it's very small, they don't have to have surgery. If it's very small, you will hear this continuous machine-like murmur. Okay? And it's at the inferior left clavicle. Okay? The next one, ventricular septal defect. Where do you hear it? Right here. What's the ventricular septal defect? Where are we hearing this?
That's the fourth.
We're actually hearing it right at your tricuspid area. Why are we hearing it at the tricuspid area? We said that blood in ventricular septal defect goes from an area of higher power to an area of lower stress. So the left ventricle is where it's going to be really high, so it's going to shoot over to the right. Okay? So usually you hear it more right here by the tricuspid valve. Okay. So ventricular septal defect, left sternal border, fifth intercostal space. That's where you hear. So the three things that are abnormal that I want you to pay attention to is aortic regurg. You hear it at Erb's point. Okay. The patent ductus arteriosus, you hear it in the left clavicle, inferior left clavicle, and the ventricular septal defect, you hear it at about the tricuspid valve area. Okay. All right, guys. Okay, so continuous murmurs. The continuous murmurs that we do have, you're going to hear that are going to sound true systole and diastole are your patent ductus arteriosus and ventricular septal defect murmurs. These are holosystolic or pansystolic murmurs that you hear throughout systole and diastole. Okay? Your patent ductus arteriosus is failure of the duct between the pulmonary artery and the aorta to close. So the pulmonary artery, does it have oxygenated blood or deoxygenated blood? Deoxygenated blood. And in utero, it doesn't matter. But out of the what is it?
Slurred speech.
No, I just don't. I can't bring it to help. I don't have one. The uterus. Mine's gone, so forget it.
There's another
67. 67.
There's a new PowerPoint that's
Six-
cardiovascular assessment revised 2020.
But it's in
Yeah, so I added it.
6-7.
It's there. That's just the one
67.
you were typing on
Yeah,
last
but they're
week.
the wrong PowerPoint.
No, I have the one with all my notes on it.
The one you said.
You can just cut and paste the slides over. It's a few slides, cut and paste them.
And this slide, okay.
You'll be okay. Just do them on the new PowerPoint and then cut and paste them over. So, patent ductus arteriosus, failure of the closure between the pulmonary artery and the aorta to close. Remember, before birth, that's okay. After birth, it should close by day 3. Okay? It's a continuous murmur, left upper sternal border, inferior to the clavicle. It's a machine-like, and it's definitely a holosystolic or pansystolic type murmur. It is associated with cyanosis because of the fact that we have oxygenated and deoxygenated blood mixed. And there's not enough oxygenated blood to meet the body's metabolic demand. So a lot of times patients end up with cyanosis. If it's a huge one, they will end up with really severe cyanosis. Okay? This is what it looks like. This is that area here where the pulmonary artery is, and the aorta, and they have this opening here that blood goes in and out of. Again, a very tiny one, usually don't affect the patient that much, and they can actually live with it. All they have is a murmur, but a huge one will definitely need to be repaired. Ventricular septal defect is a very harsh holosystolic murmur, left sternal border at the 5th intercostal space, okay? This is usually, you can see it in older people. You read the story of David Goggins. He's like that ultra marathon runner that does all this crazy stuff, and he actually had a ventricular septal defect. He actually went through the Navy SEAL training 3 times with that ventricular septal defect, and was not picked up. This guy was running ultra marathons, and it was not picked up. How in God's name he survived and didn't die is amazing to me. Like, I follow him on Instagram now after reading his story, because I was like, dang, dude, like, you're godsend. Because for him to run those ultra marathons, he run like a 100-mile marathons and these kind of things with a ventricular septal defect. Yeah, they have 100-mile races. People are crazy enough to do this. People do that. One thing that he did notice when he was in Navy SEAL training is that he kept getting this pneumonia and he kept coughing up blood.
Oh, there you go.
From the pulmonary hypertension. But he attributed it to pneumonia. Okay? They didn't find this until one day he just kept feeling really, really sick. They found it like, after he had run and gone through Navy SEAL training and actually been a SEAL. That's when they found this thing and repaired it. Okay? Respiratory infections are very common. They usually go into heart failure. Okay? And usually the kids are symptomatic between 1 and 6 months. So usually they repair it by then. For some strange reason, they missed his. And he lived until a nice adult with it. Again, the blood moves from an area of higher pressure to an area of lower pressure. So it goes from the left ventricle to the right and shunts over to the right ventricle. Okay? This is where I thought I was. Heart sounds. Very important. I want you guys to remember where these are and what causes them. So we know S1 is closure of the AV valves. We know we use the diaphragm of the stethoscope to listen for S1 or S2, right? Because those are high-pitched sounds. Oh my God, the table just pulled my skirt apart. Those are high-pitched sounds. For low-pitched sounds, we use the bell. Okay? So S1, closure of the AV valves, It is best heard at the mitral location. If you want to hear S1 the best, listen at the apex. Okay? That's a test question.
Yeah.
I'm gonna ask you where I need to listen to it. S2. You're gonna hear it more at the area of the aortic valve. So not the apex, but the base. So you're gonna go at the top to hear S2. So S2, you're gonna listen over the aortic valve. And you're gonna use the diaphragm. So S1, apex, S2, base. S1 by mitral, S2, aortic. It can come in any one of those fashions. I want you to be able to just pull it out and throw the answer and move on. Okay? Base at the top, aortic valve, S2. Apex at the bottom, mitral valve, S1. S2 split. What happens in an S2 split? You guys remember we talked about it last week?
During inspiration.
Inspiration is physiologic. Expiration is pathologic. Remember, we said that if it's at expiration, you know that there's something wrong. It's associated with a left bundle branch block. Okay? If it's coming on expiration. If it's on inspiration, it's physiologic. On inspiration, why does it happen? I know. Why does it happen on inspiration, my love? Tell me.
Was there a delay in the pulmonary valve to close?
Yes. Volume, because it actually, there's a delay. Remember, the aortic valve closes before the pulmonic valve. Okay, so there's a little delay in there. When you take a deep breath, you increase your intrathoracic pressure, you actually allow more blood to go into the right ventricle. So that actually delays the pulmonic valve closure just a tad. Okay? On expiration, you should not have a delay. If you have a delay on expiration, there is something wrong with the aortic valve. It's closing late, okay? And that's usually associated with some kind of pathology, like left bundle branch block, okay? Some books say right bundle branch block can cause it too, okay? Where do you listen? You're gonna listen at the area of the pulmonic valve. Where's your pulmonic valve? Left sternal border, second intercostal space, left sternal border. All right. S3. S3 is a rumble. Okay. So you're not going to hear it with the diaphragm. You're going to hear it with the bell. It's low pitched. It's a low pitched rumble. All right. When do you hear S3? What causes an S3 sound? Increased fluid volume states. When is it normal? Pregnancy. What else? Adolescents, young people.
Athletes.
Okay. When is it pathologic? Heart failure. Okay. Increased fluid volume states. S3. Kentucky. Okay. That's your S3. Where do you hear it best? At the apex, in the left lateral recumbent position. So you're going to put that person to lay on the left side, and you're going to listen at the apex. If there's an S3 sound, you will hear it there. Okay. S4. We said that's an atrial gallop. Why is it an atrial gallop? Yes, the wall is stiff. So the atria is trying to push that last atrial kick against that stiff ventricle, and it gives it a little push back. So you get that atrial gallop. That's where you get that Tennessee. All right? Remember, it's also low pitch, so it is heard best with the bell of the stethoscope. Okay? And it's a non-compliant ventricle. It's a stiff ventricular wall. Anything that gives you a stiff ventricular wall, an MI, hypertension, all these will give you a stiff ventricular wall. Okay? That's where you get your Tennessee. That's your S4. That's your valve you're gonna listen to, and you're gonna listen to that, for that, at the apex with the mitral valve. Okay. And now, pericardial friction rub, you will hear for an inflamed pericardium. You get an inflamed pericardium with pericarditis, okay? That's when most of the times you get an inflamed pericardium. You hear it best at the left sternal border when the patient is leaning forward, okay? You will hear it. It's a harsh rubbing type sound that you hear, and no matter which part of the stethoscope you're listening with, you will hear it, okay? A pericardial friction rub is synonymous with pericarditis. So they're telling you that your patient came in and your patient was complaining of chest pain anytime they laid back. They couldn't lay back because the pain got worse. The pain was worse on inspiration, because remember, it's pleuritic type of pain. The pain is worse on inspiration, and it gets better when they lean forward. Listen for the pericardial friction rub, because it's probably pericarditis. And when you look at the EKG, what are you gonna see? Diffuse ST elevation, okay? And they have that gas, you have that smiley, okay? So you're gonna look for diffuse ST elevation, okay? There's no particular rhythm or pattern, it's just diffuse throughout, okay? This slide is very important. I need you to know where things are and why they happen. So pay attention to this slide, please. All right? Other tidbits. These are pulses that we're going to listen to. Pulsus alternus. Pulsus alternus is when you're palpating someone at the radial pulse. You take their radial pulse and you're palpating, and you get this nice bounding, then you get nothing. Bounding and then a very light. Bounding and very light. It's a regular rhythm pulse, but it's bounding and then light. These patients likely have left ventricular failure. That pulsus alternus, anytime you see it in a test question, the answer is likely left ventricular failure. Okay? Because that's the one thing that actually does cause that bounding pulse, that light pulse, bounding pulse. Okay? Paradoxical pulse. When do you hear that? Tamponade, when the heart is being squashed in tamponade. Okay? And usually, when do you see, what do you see? When a patient takes an inspiration, when you're doing their blood pressure, when they take a deep breath in, their blood pressure systolic normally drops about 8 to 12 millimeters of mercury. Okay? That's normal. When they have cardiac tamponade, it drops greater than 20 millimeters of mercury with inspiration. Okay. Why would that be a problem? Why do you think systolic blood pressure will drop so low? When I take a deep breath, what happens? Increased pressure, like the acid, right? And then what happens? If I have a heart that's already being squished, what usually happens?
Isn't it more?
I'm squishing it more, one, but when you squish the heart, usually what happens, the septum moves to the left. So the left ventricular outflow is going to be obstructed. So the systolic blood pressure drops significantly. Okay? So in pulsus paradoxical pulse, you would see that a lot with cardiac tamponade. You can see it also with constrictive pericarditis, because constrictive pericarditis kind of constricts the heart the same way. But usually, you're going to see that, you're going to think cardiac tamponade, okay? And usually the question would be something like the patient is in some acute respiratory distress. He takes a deep breath and his systolic blood pressure drops from 160 to 100. Okay. That's a really ridiculous drop. hyperkinetic, which you see a lot in cardiac tamponade. Right? If you're working in an open heart unit and you see that happening with your patient, be very astute and know that you have to call a cardiac thoracic surgeon because they're probably bleeding into the pericardium. This is a whole lot of words and you can read it on your own time, but it's basically what I just said. If you don't believe me, read it. Okay? This is how this works. Inspiration, you increase your venous current. The right ventricle enlarges, the symptoms pushes to the left ventricle. The lungs expand, pulmonary vascular expands, more blood pools into the lung, and it decreases filling of the left ventricle, which decreases your stroke volume, decreases your pulse amplitude, and in turn decreases your systolic blood pressure, decreases your cardiac output, and therefore puts this patient at serious risk for compromise. All right? Your patient is in cardiac tamponade, you do not want that patient on your floor, you want that patient in somebody's OR really quick. Okay? These are pulses and morphologies that we need to look at. Pulsus tardus, you usually see it with aortic stenosis, and you palpate the pulse, and the pulse, the amplitude of the pulse slowly gets higher and higher and higher. Okay? That's usually pulsus tardus, and it's associated with aortic stenosis. In a question like that, it's going to be an older person. Aortic stenosis is usually with an older person. In your test questions, it's going to be the typical stereotypical patient. Okay? So if an aortic stenosis, if it's a 25-year-old, you know it's HOCM. If it's a 75-year-old, you know it's aortic stenosis. Okay? Because it's usually older people who get aortic stenosis. And usually what happens in aortic stenosis is they'll complain of things like syncope and what do you call it? Angina. Okay? Because they get low cardiac output because of the aortic stenosis, and as a result, they get decreased perfusion to the myocardium. So they get and decreased perfusion to the brain. Okay? They usually get syncope and angina. Right? In these patients, they have this pulsus tardus. So if you see pulsus tardus on a test, you know the pulse is slowly, the amplitude of the pulse is slowly increasing. It's associated with aortic stenosis. Okay? Pulsus bifidus is usually this high amplitude of a pulse, and then it comes down a little bit, and then a high amplitude again. And it's a really sharp pulse that comes with a HOCM. Okay? HOCM, hypertrophic obstructive cardiomyopathy. Right? We talk about this. And aortic regurg can also have this. Remember, aortic regurg is a systolic or diastolic murmur?
Systolic?
Diastolic. Okay? Regurgitation. What is the aortic valve doing during diastole? It should be closed. So it's diastole. So for regurgitation, remember, the valve is supposed to be closed. Come on, guys, I need you to get this really well. That's how you can spit it out on the test really fast and move on. Okay? Pulsus, so in HOCM, you know it's going to be systole. If it's aortic regurg, and they're talking about pulsus bifidus, if they're talking about a systolic murmur, you know it's HOCM. If they're talking about a diastolic murmur, you know it's aortic regurg. Does that make sense? All right? Pulsus alternus, the answer to this question is left ventricular failure. All these tables are pulling my skirt apart. Look at that. That's your Sue Barry. All of them. That means I need to stand in the front of the class. That sucks. Okay. What will give you a hyperkinetic pulse? What do you think? These are usually high output states. What gives you high output states? Are you sepsis probably? Thyrotoxicosis, metabolic. Okay? Patent ductus arteriosus. anemia, fever, all high output states. They can give you a high bounding pulse. Okay? If they have a bounding pulse and they have bug-eyed, they have hyperthyroidism or Graves' disease. Okay? If they have a bounding pulse, murmur at the inferior left clavicle, that's holosystolic, and they have the fingers are cyanotic, they have patent ductus arteriosus.
Jesus.
Okay? Hypokinetic states, low output states, shock. A shocky person will give you a low output state. That make sense, guys? You just have to learn it.
Yeah.
You just have to pay attention and learn it. Alright? Cardiac examination, we know where our points are. We know where to listen for them. Because if I move this and it said, Carolina, where's your mitral valve? Girl, I'm gonna hit you. I said, where is the mitral valve?
Fifth intercostal.
Fifth?
Midclavicular. Left sternal border.
I'm about to give you a heart attack here. Erica, where's your tricuspid valve?
Left. Fourth.
Sternal border, left of the sternal border. Okay? Alright guys, you need to know that. Like you need to know it. Like it's like it's the back of your hand. You need to know that. That's what's gonna help you. Alright? Percussion. When do I need to percuss? When during the cardiac exam do I need to percuss? Huh? Size, yes.
Looking
What
for
else?
air. Are you looking for air?
Following, found. What about dextrocardia? Dextrocardia means that their heart is where?
On the right.
Right side. Okay? So in order for me to locate it, I may have to percuss. If I'm percussing over air, what am I going to hear? Hollow, tympani. If I'm percussing over the solid, what am I going to hear? Dull. Okay. Jugular venous pressure. We talked about this. Where's the angle of Louis?
What?
Where's your angle of Louis?
I forgot what that is.
Here in the middle? What does here in the middle call?
What's a sternum?
This little hump right here, yeah, it's different. It's the second intercostal space right here in the middle. Okay?
What is it called?
What's below the angle of Louis? I'm going to tell you because I haven't told you yet. It's the right atrium. It's 5 centimeters below the angle of Louis. Okay? 5 centimeters below the angle of Louis. The right atrium is 5. I put it on the other slide so you can see, so you don't have to type it. It's right there. Guys, you don't have to type it. I put it there. I just want you to pay attention to it. I put most everything in the slide so you can just pay attention to it. I like attention. I'm a Leo. We're very attention seeking. Okay? All the Leos in the room know it. So don't front. We're all the same. We're very attention seeking. Some of us do it on the DL, some of us are blunt with it. I'm one of those. It's in your PowerPoint, you don't have to type too much, it's there, okay? So, when you're assessing the jugular venous pressure, you're looking for what? Right atrial pressure. Why are you looking for right atrial pressure? What disease process are you trying to find out? Pulmonary? Yeah, possibly. But pulmonary is usually left-sided. Right heart failure. Okay? Usually you're looking for right heart failure. Okay? And what are the signs of right heart failure? JVD, hepatosplenomegaly, and peripheral edema. Those are the three things I want you to look for. JVD, hepatosplenomegaly, and peripheral edema. Okay? Those are all synonymous with increased right ventricular workload, or increased right ventricular flow, or increased right ventricular pressure. Okay? You'll see that. How do we assess? How do you assess for JVD? Which side are we looking at?
Right side.
Right side. Okay? So you're looking at the right internal jugular vein. Okay? And a lot of times the right internal jugular vein, it oscillates a little bit, especially with this tension. So it's almost like you're looking at it and you're going, is that the artery or is it the vein? If you depress it, the oscillation will go away if it's the vein. If it's the artery, you'll feel a pulsation. Okay, that's how you distinguish between the two of them.
I also see them when they turn to the left, like they'll push down on their abdomen.
Oh yeah, that will see it rise. And that's the hepatojugular reflex. Okay? Okay? You'll see the hepatojugular reflex.
They were trying to go central line, and he was like, press on the lip.
Yes, you see it. So when you're assessing these patients, you want to make their head of bed at 30 degrees. You keep them at 30 degrees. You want to make sure you have good lighting. You're going to measure at the highest point of the right internal jugular vein. So you're going to look for the highest oscillating point of it. And then you're going to measure it at the angle of Louis. Have a nice picture here. Look at it. Okay?
They do that all the time.
Huh?
They do that all the time.
I'm sure they do. Would they just slip a catheter in and measure it for a machine?
All the time.
All the time. Right? So the fact that you don't have to do this in the bedside, but you have to know it for your exam. Again, the right atrium lays 5 centimeters below the angle of Louis. Okay? So when you're measuring, what you're going to do is measure at the highest point. Anything that you get, let's say you get 5, you're going to add to 5. Because you're factoring in for this 5. So you're going to get, let's say I measure it, and the ruler here is going to come up to 5 centimeters. If it comes up to 5 centimeters, I have to add 5 centimeters, so my jugular venous pressure is actually 10, not 5. Anything greater than 8 signifies increased jugular venous pressure. So 8 is your magic number. It's in the PowerPoint, guys. It's there. Trust me. Just trust me. I put it there. It's there. Okay? Anything greater than 8, you're in trouble. So you're going to measure, again, the highest point to the right jugular vein, and you're going to actually add 5 to it. Because 5 is the distance between the angle of Louis and the right atrium. So if it's elevated, if it's greater than 8, it's elevated. How are we going to treat this patient? Probably with diuretics, okay? Something like that. All right? Does that make sense, guys?
See.
Yes. Carotid assessment. How do we assess the carotid pulse? We're going to inspect auscultate. Remember, a bruit, when you're listening to a vessel, is turbulence, and it's synonymous with, like a murmur. So you hear a murmur at the valve, that's the humming, and you listen for a murmur, and you palpate for a bruit. Okay? A murmur, and put your hand on the chest, and you palpate for a thrill, but in the carotids, it's a bruit. I'm sorry. You listen for a bruit and palpate for a thrill.
Okay.
Sorry, the vessels.
Well, with Tina Jones,
Oh God.
it's like I heard a bruit everywhere, so she's really sick.
You heard a bruit everywhere?
Yes. I was
Use the bell?
no, it's a shadow.
Did you use the bell for it?
With that sick woman.
It's like that's a bruit everywhere. I was discussing that with him today.
And she is not I can't use non-compliant anymore.
You're done hearing, you sure can.
Thanks for telling me.
Alright,
That's her responsibility.
I got confused when I heard a bruit everywhere. I'm like, okay, so am I supposed to hear that or not?
Yes, that was my thing too. What was I supposed to be?
so, let me ask you a question now. So I'm listening at the aortic valve, and I hear a murmur. And then I palpate over where the aortic valve should be, and I feel a thrill. Does that increase my murmur scoring?
No.
Yes.
Why do you say no?
Yes. It's a 4. Yes.
Yes. A murmur without a thrill is a 3. A murmur with a thrill is a 4.
Yes.
Yes.
That's why I know.
Okay.
I know about 1 and 2, 5 and 6.
Palpation. The general rule: fingertips, pulsation, base of the fingers, thrills, and base of the hand, heaves. Heaves are like fluid flows that you'll feel. Huh?
How would that look like?
Oh, that's really palpating the chest.
Oh, okay.
Yes.
Oh, okay.
To palpate the carotids, I hope you know that you use your index finger, your middle finger, and you palpate. I know you're trying to test me, right? That's what it is? You're trying to make sure. Alright guys, so areas of palpation. You're gonna palpate over the aortic area, same, second intercostal space, right sternal border, pulmonic area, second intercostal space, left sternal border, left sternal border, third intercostal space, where it's Erb's point. You're gonna actually palpate for the pulmonic area, or the ventricular area, the right ventricle area. The epigastric xiphoid process, if the person has an enlarged heart or enlarged myocardium due to COPD, you can palpate there. And at the apex, the left ventricular area, you're gonna palpate right fifth intercostal space in the clavicular line. What's
In
going
my
on?
mind vision, it's her, and all of them are doing all of this. That's what I'm talking That's all I can see.
Guys, why are you doing that today, babe?
So like it makes a difference.
It doesn't make a difference. Still, I'm sure it's like a. Guys, stop trying to arouse David. It doesn't do anything.
She's used to it.
I am used to it.
He is. So you should be. That's what I was about to say. You should be used to it by now.
I'm immune.
All right, dextrocardia. This is what your chest X-ray looks like for dextrocardia. Right? So your test question is gonna sound something like this. You go to percuss, listen to the patient's heart sounds, and you hear the S1 displays towards the right. You percuss over the left, and you hear timpani, and you percuss over the right, and you hear dullness. Okay? Your patient's cyanotic. What is likely the cause?
Dextra cord, yeah.
Tachycardia. Right. C2 inversus.
We had a patient like that, open heart.
Really?
Yeah.
But it was complete, you
Like
just
everything.
stomach and
Everything is
That's it.
flipped
That's
in
it.
situ inversus. The heart is on the right side, the trilobular lung is on the left side instead of the
Wow.
right. The liver is on the left, the spleen is on the right, the stomach is on the right.
Jeez.
Does the brain work the same way?
Huh?
Is the brain twisted too? The ventricles? I'm not trying to make it, it's a real question.
That's a good question.
I don't know.
I thought it was your question to you.
Just flip the front in the back in the front.
I don't think so.
Everything else is flipped,
Hilarious. Come to think of it, that's not a bad question.
Right?
Everything's
Wow.
flipped.
No.
Everything else is flipped.
Everything else is flipped. Why not? What kind of problems do you think this person will have?
Everything.
heart issues, because they're having open lungs
Heart issues, they're having open heart surgery.
and a broken heart.
They have a broken heart. They probably have a lot of pulmonary issues. They probably have a lot of cyanosis in these patients. They may have, I'm not sure. How old was this person you guys did open heart on? They lived for that long.
He was in his,
He was young. I received him.
he looked old.
He looked.
Well, he might look old because he's going, I mean, his body's like that.
50s.
Well, he lived 50 years with everything flipped, so.
It was weird, all the lines were faced
Yeah.
opposite too,
All
like,
the like, yeah.
we usually have all the IJs
On
and
the right.
they're on
Right.
the right and everything, and then
One,
everything was on the left on him, so you kind of.
Trying.
Yeah.
He fucked us up.
Oh, sorry.
Alright, heaves and lifts, rhythmic lift of the fingers, it's usually like a wave fluid. Enlarged atrium will give you that. Thrills, again, there are murmurs, they accentuate the murmur, the grading of the murmur changes if you have a thrill. To palpate, the right ventricular, intercostal space, left sternal border, we just looked at it. Palpate S1, S2, of course, you're gonna use, I don't ever advocate for this, and I'll never test you on this, because I think palpating it just doesn't, for me, I've tried it, and I can't really tell S1, S2 by palpating. So if you ball the pressure on the chest wall and you feel the carotid upstroke, if I listen with my stethoscope to the mitral valve and I palpate the carotid at the same time, I actually can tell you which one's S1 and one's S2 because you feel for the upstroke and you hear it at the same time. But to palpate, I have never been able to do this. To actually palpate with pressure on the chest wall and feel for the upstroke, I have never been able to do it. And they said when you feel for the upstroke, you can tell which one's S1 and S2. If I listen, the upstroke, I can feel the upstroke is S1 and S2. I can actually listen and I can say, oh, that's S1, that's S2. But you have to listen to it for a while. But if you're palpating, it's so hard. But you can actually palpate it, just so you know. But you actually, Please don't hold both of your carotids at the same time. Don't do that. Okay? One at a time, please, one at a time. No CPR today. Okay? All right, we talked about, palpating for JVD. Okay? Carotid pulse, so when we're examining the cardiac patient, we need to have the patient in a 30-degree elevation. We're gonna palpate for jugular venous pressure. Carotid pulse, we wanna look, feel for. Inspection, we wanna look for any sunken chest or pigeon chest, as we call them. We want to palpate for where the valves are. We want to listen with the bell and the diaphragm for murmurs, rubs. Okay. We want to listen for high pitch and low pitch sounds. When we're putting patients in the left lateral decubitus position, we can palpate for the point of maximum impulse. The point of maximum impulse should be no more than 2.5 centimeters. Okay. And it actually, if it's wider than that, it can indicate that there's some stretching or cardiomyopathy. Remember, it's 7 to 9 centimeters left of the sternal border, so if it's 12, that means it's going all the way in, so it's usually left ventricular failure. Okay? If it's at the xiphoid, it's usually COPD or some kind of, sometimes right ventricular failure can do that too. Okay? Sitting forward, sitting and leaning forward after a full elevation would, you're gonna listen at the apex of or the border of the apex, and that usually can bring the, what do you call it, the apex closer to the chest wall so you can hear what's going on a little bit more. Point of maximum impulse, again, should be less than 2.5 centimeters. If it's greater than 3, it's a problem. If it's greater than 4, it's even worse. Okay? Thank you. Hyperkinetic, we talked about if we have a pulsation that's hyperkinetic, we're thinking hyperthyroid, we're thinking anemia, high output states. Okay? If it's hypokinetic, we're thinking cardiomyopathy. Okay? Left lateral decubitus position. If we're putting, if there's a lateral displacement, there's fluid overload. Medial displacement, COPD. Medial is going to the xiphoid process, lateral is going onto the axilla. Okay? So they would say something like lateral displacement, or the question will say something like you hear it more at the axilla. If they say axillar or lateral displacement, you know we're talking about left ventricular failure, it's displaced. Okay? If they talk about a xiphoid process or medial displacement, it's more likely COPD, some kind of pulmonary issue, can actually give you that. Okay? Any questions on those guys?
In the exam for the competency, are we still palpating for the murmur?
They did not put that as part of your exam for competency. You can actually palpate the chest. When you palpate the chest, you're going to palpate in the same areas. Okay? But you don't have to say there's a murmur or anything, or if you feel a thrill. You can say no thrill. According to Dr. Yakub, they want more practicing in the lab. You guys are not going, apparently. You guys need to start going. I'm gonna make a gallant effort to go on some days, and I'll let you guys know when I'm going, so that you guys can,
It seems like Thursday's covered, but
Thursday,
Tuesday-
all days covered, yes.
yeah, because Dr. Abuja goes there, but on
yeah.
Tuesdays, there's no one.
Well, the thing about it is, if you just let us know you're there, somebody will come. The problem is that somebody goes there early in the morning and there's no students, so they leave.
Because it says from 8:30 till 10, there's no faculty, but from 10 to 12, there's
There
supposed to
usually
be
is.
faculty there. So
I don't know. I'm gonna tell you, I'm gonna make a gallant effort to go, but Barry University has a way of not paying people, so I don't think so. Yeah. You can't do Tuesdays before class? Well, not next week, but the day of your exam, we're not gonna have class after your exam, but we're gonna go to the lab. So I'll be there with you guys then, okay? So you can actually count those as some of your hours.
What day is that, Dr. Moore?
That will be, the exam is on the 18th.
2 weeks from today.
2 weeks from today. I'm not here next week, but the day after the exam, on the 18th, I'll be there. So I'll actually go to the lab with you guys and, so we can practice after the exam. Next week, you're meeting at 1 with Dr. Albuha. She's gonna meet you in 103, yeah, library 103. All right, guys? All right. Cardiovascular history. We talked about this a little bit. Why is it so important? We need to know what happened, when did it happen, when did it start, what's going on with the patient, what other problems do they have? Chest pain. When is the chest pain when is the chest pain present? Is it on exertion? Is it all the time? Is it on inspiration? Is it sharp? Is it dull? Is it pressure-like? Is it heaviness? Okay? Because that will tell us if it's pulmonary versus cardiovascular. Does it happen if I palpate? Is it worse? Did you do some exercise prior to this starting? Because it could be muscular, skeletal in nature. Okay? Does it radiate anywhere, to the left arm or to the jaw? Okay? Is there associated numbness or paresthesias? That would be associated with things like neuromuscular issues. Okay? Dyspnea. Is it dyspnea on exertion? Is the dyspnea worse when you move around? What's going on? Is there a cough associated with it? Okay? We have dyspnea, we have paroxysmal nocturnal dyspnea. That means every time I lay down at night, I can't sleep, I have to get up and dyspnea starts. Okay? Orthopnea. I can't stay back. Okay? Short breath starts. Hemoptysis. Okay? Spitting up blood. Is there syncope associated with it? That usually means that there's a low output. Okay? And a lot of times when there's a low output, there's some kind of valvular or structural lesion that's causing it. So if they're talking about syncope and chest pain, think low output. Okay? Think about things like aortic stenosis. That's one of the number one things that will cause you a low output state. Okay? Is there palpitations associated with it? Are the palpitations constant? Do they come and go? Okay? If it's a constant palpitation, is there anything else associated with it? Do they have ophthalmia? Or do they have bug eye? Their fatigue associated with the chest pain, okay? Have they had some kind of infection associated before? Cardiomyopathy, Coxsackie virus is the number one cause for infectious cardiomyopathy, okay? So you want to see if that's a problem. Edema, is it right-sided versus left-sided? Left-sided will give you the dyspnea, the respiratory symptoms. Right-sided will give you the systemic symptoms, like the JDD, hepatosplenomegaly and such. Okay. Peripheral vascular disease. Does it include claudication, neurogenic claudication versus just I'm walking and my leg hurts really, really bad? Skin changes. Is it Paula? Is it rubor? Okay. Is there pain? Is there significant edema? Do they have hypertension? Do they have diabetes? Remember, diabetes, the diagnosis of diabetes is almost equivalent to having one heart attack because angiogenesis is blocked when you have diabetes. okay? They cannot produce new, blood vessels in the heart, so that collateral circulation is diminished. When we do cardiovascular exercise, we can actually push the heart to generate collateral circulation, so we get more vasculature. If we have diabetes, it blocks angiogenesis, so they don't have the ability to do that, okay? So they actually are higher risk for cardiac symptoms. Okay? Family history. If your dad died from heart disease, his dad died from heart disease, his dad died from heart disease, his dad died from heart disease, and your brother died from heart disease, and his brother, and your next brother,
You
he
die
probably
from
died
heart disease.
Very likely. You know? Right?
Yes.
Makes sense, no? Family history is very important. Cardiovascular risk. Smoking, you see it's at the at the top, okay? 30 pack a year history, very significant. Diabetes mellitus, we just talked about it. Blocks angiogenesis. Obesity, dyslipidemia, sedentary lifestyle. Stress, we talked about the Takasugi heart, broken heart syndrome. Hostility, type A personality. That's why you people like to say, oh, I'm type A. No, I'm not type A, I'm type B. Oh, no part of that type A thing. They get heart attacks, they get strokes. No, I want to be type B. Males, remember women after age 55 or 50, some books say 50, some books say 55, we lose our estrogen protection. So when we lose our estrogen protection, we're more prone to having heart disease at a later age. Okay? Positive family history, our families doom us. And increased C-reactive protein. It has been associated with increased cardiovascular risk. Examination, we're doing a general assessment. We're going to look at everything. Remember, looking at the fingers can indicate cyanosis. Listening to the lungs can tell you that there are crackles or rales. Looking at the eyes can tell you if they have high output states like hyperthyroidism. Looking at the lips can indicate cyanosis, so you know you're not putting out. Looking at the legs can show you edema, okay? Looking at the abdomen can show you a distended liver and spleen, okay? So everything plays into it. You can actually detect cardiovascular disease, not just by listening to the heart and palpating the pulses, but doing a general assessment because you have other things that can contribute to the cardiovascular compromise, okay? Inspection, we want to look at the chest cavity. Do we have pectus exacerbatum? Okay. Do we have scars? Did we have a open heart surgery at some point? Okay. Auscultation. We're listening for murmurs, rubs, gallops. Okay. We want to hear if those things are present because then we know that there's a valvular problem. Okay. Some kind of disease process. Palpation. We want to palpate for thrills because that would change the grade of our murmur, right? Okay. Percussion. We want to know where our solid organs are. We percuss over solid organs because we want to know where they are. That will tell us if we have something in the wrong place. It's a nice picture. I don't know why I have that there, but what? Makes sense. Chest pain characteristics, when and where. Palpitations, we already talked about it. Is it constant? Does it come and go? When did it start? Okay, shortness of breath, with exertion or without exertion. Okay, am I just bubbling? Is there dyspnea? Is there orthopnea? Is there paroxysmal nocturnal dyspnea associated with the symptoms? Okay, has there been weight gain over 2 days? You gain weight over 2 days, a considerable amount of weight. It's not your scale. Something's wrong. You're retaining fluid. Okay. Upper motion. Screening and control of hypertension is the most important things we can do because hypertension accounts for 35% of myocardial infarction and stroke, 49% of heart failure, and and 24% of all premature deaths. When do you screen for hypertension? Every 2 years. Depending on age, and if you have a history, a very strong family history, you actually screen with every healthcare visit. Huh? Every day. Well, if you have the disease, you should be taking it every day. If you don't have the disease, you're kind of like obsessive looking at that thing. JNC7, we still use the JNC7 guidelines to grade hypertension. We use the JNC8 guidelines to treat hypertension, okay? JNC7 says normal blood pressure is less than 120 and less than 80.
Doesn't matter height, weight, something.
No,
Has to be
has to be less than 120, less than 80. Okay? Pre-hypertension, 120 to 139, or 80 to 89. Okay? Lifestyle modifications? Heck yes. Do we do lifestyle modifications for people who are less than 120 over 80? Yes. Because we want to prevent them from getting hypertension. Okay? Stage 1, 140 to 159, or 90 to 99. Lifestyle modifications, of course. Don't look at the drug therapies because we're using JNC8 now. Stage 2, greater than 160, greater than 100. JNC8, and this in pharmacology. Okay? JNC8 goes by age. Also, they factor in, is there diabetes present or chronic kidney disease present? And that tells you how you're gonna treat them. They also factor in, is the patient black or non-black? Okay? Those make the difference. Because whereas a black person, you may start them on calcium channel blockers, diuretics first, if they have nothing else going on. For a non-black person, you probably start them on an ACE inhibitor first. Okay? JNC8 says everyone with diabetes, hypertension, diabetes or kidney disease, you want to start them on an ACE or an ARB. Okay? Black, non-black, 65, less than 65, doesn't matter. Okay? JNC8 also says that your blood pressure goal does not depend on where you are. Your blood pressure goal should be the same for everybody. Okay? It also says, however, that patients who are greater than 60 years of age, they may have a higher target blood pressure than people who are less than 60 years of age. Because as we get older, our vessels get stiff, and if our vessels get stiff, our body has to actually pump a little harder to go against those stiff vessels. So our systolic blood pressure is going to be a little bit higher. So less than 150 is okay for these patients. Okay? We do that a lot of times. We take the patient who's like an 80-year-old who comes in, blood pressure is 170, and we decide to make it 120. And we don't know why they can't get out of bed, why they don't want to walk, why they're confused. We can't figure it out.
For everybody.
But we just like completely decreased all perfusion to their brain. So we knocked their blood pressure down too low. Okay? So we want to pay attention to these. Compelling indications. Compelling indications tells us that if your patient comes in and they had an MI, and now they have a touch of heart failure, and they're African American, you're not gonna start them and a calcium channel blocker and a thiazide diuretic first. You're gonna put them on a beta blocker and an ACE inhibitor, because now they've had an MI. So these compelling indications override JNC8, because the treatment parameters at post-MI says that you must send them home on an ACE inhibitor to prevent ventricular remodeling, and you must send them home on a beta blocker. Alright?
Is there like a specific dose? Like, let's say you have an MI, everybody that has an MI is gonna get 10 milligrams of lisinopril or 25 of chloride, or it's
No,
just.
they're gonna actually have to get whatever they tolerate, as long as you put them on one. So if you're tolerating only 2.5, you'll get 2.5.
But you have to start with the smallest dose though,
Start low
and then
and go slow.
gradually.
Start low, go slow.
That doesn't say the raise though.
No, this doesn't say race, this is just a Medscape slide. What did you say? What is what?
There's Palpation blocker, but it's although and. I don't know if that's that question. What does that mean?
Aldosterone antagonist.
That's what I'm talking about.
That's what she said though.
What?
Did you say aldosterone?
Yeah, but I wasn't sure.
She was just making-
Oh, okay, okay. And this basically are your compelling indications. Remember, your compelling indications are what you're gonna treat. So just because JNC 8 says that if it's African American, we're gonna put them on a calcium channel blocker, and you know that this person has heart failure, please tell me that you're gonna put them on an ACE inhibitor. Okay? Please don't tell me calcium channel blocker, because now you gotta think about compelling indications. Huh?
We have to memorize this?
No.
Okay.
You just have to know how to treat the conditions. You don't memorize that. That's how you learn in pharmacology. So every now and then I'm gonna throw a drug question in there. That's just how it works. Hypercholesterolemia, lipid levels, less than 100. If they had a stroke or heart attack, less than 70. Optimal. Okay? Less than 200 total cholesterol is desirable. Greater than 240 is high. You must treat. Very low, low density lipoprotein. I like to call it lethal density lipoprotein, because that tells me it is bad, 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 and I must treat it. Okay? Anybody greater than 190 needs to be running on a treadmill with a hamburger in front of them. I'm telling you. Because by the time they're done, they're not gonna wanna touch a burger anymore. Okay, you just put the treadmill on high, and you put a hamburger in front of them, and have them run to try to reach a hamburger, and eventually, they will have no desire for hamburger.
Forget it.
No desire. They'll be like, forget this. I don't need this. Okay? Then you're never getting a burger. High density lipoproteins, or healthy density lipoproteins, I like to call them. Remember, for women, we need to have a higher level. So for women, we need to be greater than 50, for men, greater than 40. I'm sorry?
For women, men are different, right?
Yes. For high density lipoproteins, for women, they need to be greater than 50 to be optimal. And for men, they need to be greater than 40 to be optimal. Okay? So if a man is 40, he is okay. A woman is 40, she's actually low. And we have to treat her. Okay? Make sense? ATP3 risk assessment. Cigarette smoking is at the #1 slot. Nicotine damages your blood vessels. Hypertension's there. High density lipoprotein be less than 40 is a problem. Okay. Low density lipoprotein greater than, usually greater than about 130 you don't want. Family history, advanced age. Again, we lose our cardio protection for women at 55. Men have a higher chance of dying from a heart attack before the age of 40. Women catch up to them by the age of 55. All right. These are the updated goals. Less than 130 we want. Greater than 130, we want to consider drug options. Greater than 160, they need to be on something. Greater than 190, again, put a hamburger in front of them, let them run on the treadmill. Put it at 5, put it at like 12, all out. Don't forget that. LDL goal, less than 70 is therapeutic. Acute coronary syndrome, CHD, strokes, diabetes mellitus, they want them less than 70. Metabolic syndrome. What does metabolic syndrome indicate?
It's like a cluster of risk factors. for
Cluster of
instance,
risk factors.
okay,
But if I have everything on there, what does that say to me?
You're taking time off?
I'm gonna take time though. My likelihood of dying from heart disease is very high. Very high. So waist circumference, men 102, women 88. Fasting plasma glucose greater than 100. LDL, men less than 40, women less than 50. Triglycerides less than 150. Blood pressure greater than 130, greater than 85. Okay? These are what constitute metabolic syndrome. Peripheral vascular disease. Yay. Present in a lot of adults. Okay? Older population, much more at risk. Diabetics, much more at risk. Okay? 1 in 3 diabetics have peripheral vascular disease. Arteries versus veins, we know that arteries are very much more, much less pliable than veins. Veins are much more elastic. Arteries are much more stiff. You do not need to memorize this. But I suppose that you should know what the femoral artery and the femoral vein is. I do know that you need to know what the external jugular and internal jugular veins are. That makes sense. Carotid arteries, you should know where those are. Those are basic things. Brachial artery, if I'm gonna palpate it, you should know what those things are. You all did ACLS and BLS, right? Layers of the blood vessel, and epithelium, the outermost layer, intima, the media, the inside, and ventia, the connective tissue, and nerve fibers. Okay. Laplace law says resistance inversely proportional to the foot power of the vessel diameter. It says the smaller the vessel is, the harder I have to push. That's what Laplace law says. Okay. Arterial insufficiency versus venous insufficiency. Remember, arterial insufficiency. If there's pulses issues, it's arterial. There are no pulse issues, it's probably venous. Okay? Make sense? That's easy. Cramping pain, tired legs, muscle soreness, pain with ambulation is considered claudication. That's claudication pain. So pain when they start walking indicates claudication. Okay? Very important for you to remember. Okay? Venous, they usually have tired, achy legs. The legs get swollen when they're standing for very long periods of time. Okay? Now, if you work in a cardiovascular unit, how do your patients usually sit? Who have arterial insufficiency? If you ever walk to a cardiovascular unit, have you ever taken notice? They always have their heads hanging. If you have a patient with arterial insufficiency, you'll notice that their legs are always hanging off the bed. Next time, pay attention.
That's so true.
Their legs are always hanging off the bed. Why? We're trying to get blood flow down to those legs, down to those feet. Because it hurts when you don't have blood flow. Okay? So what usually happens when you raise the person's leg up? Blood flow goes. So what it looks like?
White.
It's white. So dependent mover, independent parlor. Okay? I lift their leg up, it gets white. I hang their leg down, it gets red and rosy. Okay? If I hang their leg down, they feel less pain. So that's why you'll see them laying in the bed and their legs are hanging off like this. All the time. If you pay attention in a cardiovascular unit, if you work in one, pay attention. Those people with peripheral vascular disease, they're always hanging their legs down. Okay? Okay, so peripheral vascular diseases, they have different types. This should not be Berger's disease, there should be B-U-E-R-G, actually B-U-R-G-U-E-R disease. Should not be spelled like burger. I got this from like a site online, and I'm reading it, I'm like, Berger's disease. Right? B-U-R-G-U-E-R, I think that's how you spell it. B-U-E-R-G-E-R, Berger's disease. Okay. PVD, peripheral arteriosclerotic disease. Of course, we know arteriosclerosis, and it doesn't matter if they affect large and medium-sized arteries. Okay. Berger's disease, this is an inflammatory condition that happens. It's very rare, you don't see it very often, but usually if you see patients with no predisposing factors and they have black fingers, that usually is what it is. It's a Berger's disease. What usually happens, they end up with like an inflammatory response, and they throw clots and clot off all the vessels to the fingers and the toes on the feet. So usually they lose digits with this disease process.
I had a patient that had Berger's disease, but he would still go downstairs.
Really? Yeah.
And
You needed to lose
he
everything.
had one finger.
You only had one finger left.
And it was like
40 years old, one finger left.
Yeah, the rest of the digits on the top were gone. I think it was just this one, and it was already losing it too, because it was already starting to go.
They actually throw these clots as microemboli, and they actually clot off all their digits. And yes, when you see them, their fingers are all black, they lose their fingers, they lose their toes. But they usually the small to medium-sized vessels that are gone. Raynaud's disease, we know is vasospastic, especially in colder weather, it's arterioles. Okay? Acute arterial occlusion, hemolytic or thrombolytic, and that's arteries. Fibromuscular dysplasia, another rare one that you don't see, but hyperplastic. They don't have thrombus formation, but they do have a lot of pain. Thrombophlebitis, inflammatory or thrombotic, and this is usually superficial, but they can get these like superficial clots that are not that are painful. Deep vein thrombosis, embolic or thrombotic, deep veins, and varicose veins. Usually the veins lose their structure of formation and they start looking jagged, and patients get like venous insufficiency. Legs are nice and tired at the end of the day. They wear compression socks. They say nurses are at high risk for these because we're on our feet a lot. This is your Berger's disease, not Berger's disease again, please. On the test, I won't put Berger's disease, I'll put Berger's, so make sure you remember. Okay. And again, it's thromboemboli. It's actually a rare form of disease that affects arteries and veins in the arms and legs. Fingers and toes are what they lose first. Okay. Arterial versus venous. Very If I don't have blood flow to my legs, will my hair grow? No. The legs are usually cool, hairless, dry, okay? Parallel on elevation, ruber on dangling, okay? Remember that. Venus, warm, thickened, mottled, pigmented areas, they're very different. They do have hair growth. They don't have the color changes with hanging or lifting as they do with arterial. Pain, claudication pain, that's what you remember. They start walking and this pain is just this sharp, stabbing, horrible pain that they get when they walk, okay? That's a claudication pain. It is really significant in arterial disease. The more advanced the arterial diseases, the worse it is, the worse it gets. Now with venous disease, they're crampy, achy, elevation does help, but they don't get the parlor on elevation. Ulcers, remember, if you don't have blood flow, any wound you have will not heal, okay? So they have severely painful, pale, gray base found on the toes and the heels and the dorsum of the foot. That one we saw over there, that was one of them. That is not Venus. Okay? Venus, they usually have these ulcers, they're like weepy, ankle aspects, the ankle you see them a lot, but they're like weepy little ulcers that don't heal well either, because they don't have the venous flow. Pulses, absent in arterial, they're usually present in venous. And edema, usually in arterial there's no edema. As a matter of fact, their feet look, they have these skin changes and their feet, the skin is dry and look almost scaly and mottled looking, as opposed to the venous, where they usually have a lot of swelling, usually at the end of the day. Ankle brachial index. I want you to pay attention to this box on the top. Now, I know that usually when we get something is wrong, the number is higher. When something is normal, the number is lower. But with ankle brachial index, it is the total opposite. The higher the number, the less obstruction you have. The lower the number, the more obstruction you have. Okay? So an ankle brachial index, 90 is normal. 71 to 90 is mild obstruction. 41 to 70 is moderate obstruction. And anything below 40 means that there's severe obstruction and that patient needs to have surgery or correction. Okay? Make sense, guys? 90 and above, normal. 71 to 90, mild. 41 to 70, moderate. Less than 40, severe. Okay. Usually put a test question on there. We do a question. We put one, the right leg at 90 and the left leg at 40, and which one needs intervention. And usually your brain reverts right back to what it's familiar with, and you go choose the 90. Do not do that. 90 is normal. 40 is abnormal. Okay? So just rewire your brain to think differently now. We talked about this already. Pain, arms or legs, vascular problems, temperature changes, cool is usually arterial. Discoloration, parallel modeling, claudication, intermittent claudication. Remember, we have neurogenic claudication that usually comes from the nerves, and then we have intermittent claudication that usually comes from the arteries. Your neurogenic palpation usually is associated with some other neurovascular issues. So a lot of times they'll have like numbness or paresthesias, okay? As opposed to the intermittent palpation where they just have a lot of pain. Redness, swelling, tenderness, okay? Circulation, cold weather, they get really pale. That usually indicates some spastic kind of disease. And that's Raynaud's you'll see that way. Ulcers, especially non-healing ulcers, look for some kind of vascular source of disease in these patients. Lymph. Your lymph nodes drain fluid, okay, from the tissues and put it back into the venous return, okay, so that we can actually just circulate our fluids through the body, okay. Edema. If we have blocked lymph nodes, we end up with changes in hydrostatic pressure, and that will actually end up with significant edema from lymphatic drainage dysfunction. Pulses, radial, brachial pulses. You can check it in the axillary, increase or decrease. Access for lymph nodes, axillary lymph nodes, you can look for. Legs, femoral, popliteal, dorsal pedis, and tibial pulses. You can actually assess from inguinal lymph nodes there. Edema, you want to look for lymphedema and measure the size of the extremity. Neuroclassification of heart disease. We're going to talk a lot about that when we talk about differential diagnoses. But just knowing that there are classifications, I'm not going to test you on this because of the fact that we didn't talk about heart failure enough, so I'm not going to test you on these. But we know from mild to severe, and severe usually you're waiting for a new heart. Mild, you usually don't have any symptoms, no limit on activities yet. Mild, slight limitation. Moderate, you have marked limitations of physical activity. Yay! You can take a small break. If you come back early, you can leave early.